It's my pleasure to have people that I can count actually for the morning course. So thank you very much for being here. I'm Tarjini Dave. I work at LV Prasad Eye Institute at the Hyderabad campus. And I've been running this course at APAO for I think about 3 or 4 years now. This time, however, I have the choicest of friends who are also delivering talks on the topic that we've put up here. This is Oops in Ophthalmic Plastic Surgery, where we thought we'll bring out some difficult situations. Unfortunately, Dr. Hunter Ewan couldn't make it, so I'll talk to you on ptosis repair and the techniques. Followed by Stephanie, who's from Singapore, Eagle Eye Aesthetics, where she has a booming practice in periocular aesthetics and surgical as well as non-surgical. She'll be talking to you on blepharoplasty, the tips and tricks. We then have Raghu from Manipal Hospital, Bangalore, who's been a very dear friend as well, who'll talk to you about implant complications, migration, exposure, and extrusion. I'll take another talk on orbital trauma, multidisciplinary management, and more on patient-specific implants, followed by Ho Sok-sa, who is from Asan Medical Center, Korea. He'll be here shortly, and he'll talk to you on revising failed DCRs. Finally, we'll conclude with another dear friend, Anasua Ganguly Kapoor, who heads our campus at Vijayawada, the LV Prasad Eye Institute campus, and she'll speak on taming the flame in ocular oncology. What are your rescue measures? So without much ado, we'll get started with the first part. Since Dr. Ewan wasn't here, I put up this talk on workhorse procedures for ptosis correction, and I'll take you through the 4 surgeries that we have in our repertoire for correction of ptosis. Levator resection, that most of us find pretty comfortable in our hands. The newest kid around the block, which is frontalis muscle flap, a little bit on Mueller's muscle conjunctival resection and posterior approach to ptosis, and then finally frontalis sling. So here's a girl who has right moderate ptosis. She has a levator action of about 6 millimeters, and you can see that I've marked the eyelid crease to match the contralateral eyelid crease. And I do that with cold steel, and then I dissect the orbicularis over the tarsal plate to expose the superior border of the tarsal plate. You can see that here. What I'm now doing is raising the undersurface of the levator, disinserting the levator from the tarsal plate and dissecting along its undersurface, and then on the superior surface of the levator. I always dissect the undersurface first because it's a very fixed landmark. You see the peripheral arcade and you know where you are. And following that, I dissect the superior surface. Here you can see that I've cut open the septum, which keeps the preaponeurotic fat pad invested. And those are the 2 layers of the septum. Septum again looks white like the levator and sometimes can be confusing, and therefore dissecting the underbelly always helps when you approach it undersurface first and then the superior surface. Once you have the desired height of the aponeurosis dissected, you generally tend to take 3 sutures. I prefer taking Prolene sutures. These are 6-Prolene sutures. And I always take the medial and the lateral suture as well, even if the central suture has given me the height and contour that I desire, because this avoids a post-operative droop. A post-operative medial droop is very common in patients with ptosis. So once the central suture has given me the height and contour that I'm looking for, the medial and lateral ones are just supporting sutures that go almost at the same height on the levator. Now here's where you can play around a little bit in terms of where the height of the medial and lateral suture goes and where the tarsal insertion goes to kind of correct the contour and height if you've not got it with your central suture. I generally tend to resect the residual stump of the levator muscle I was not pretty happy with the contour, and that's why I've taken one additional suture here. This is the playing around that I was talking about. And then you form the lid crease formation suture. I tend to take the inferior lip of the incision and anchor it to the to the cut edge of the levator, and then close the skin with interrupted sutures. And this is the patient pre-operative and post-operative at about, I think, about 6 weeks. She has a good lid height and contour which matches the contralateral side. The second surgery that we'll discuss is frontalis muscle flap, and this this is a surgery which, I think, more than me wanting to do it these days, my patients come to me and ask me that, do you perform the surgery? That's the newest surgery for ptosis, and it's gained quite a lot of popularity these days. So the initial steps are very similar to a levator resection, where you take your lid crease incision. Generally these days, this is one of my earlier recordings, I these days also harvest the levator and take sutures through both levator and Mueller's, but this is probably one of the very first surgeries. So what I've done here is gone right on the superior orbital rim, and I am isolating the frontalis muscle from above the superior orbital rim. That's the flap of the frontalis muscle that I've created, and you anchor it to the tarsus, very similar to what you would do with a levator resection. Now when you're taking both the frontalis and the LPS, the lid has a better vector and it moves posteriorly rather than moving only superiorly if you take just frontalis muscle flap. These are bulky flaps, and sometimes you may need to debulk a little bit of the frontalis, and then you go ahead and form your lid crease very similar to what you would do for a levator resection. I generally tend to overcorrect a little bit when I'm doing a frontalis muscle flap. I also see significant lag of ophthalmos in the initial postoperative period, and therefore I always take a temporary suture tarsorrhaphy lateral paramedian to avoid exposure keratopathy. I do it with a Vicryl, which tends to fall off in a couple of weeks itself. And this is how this patient responded. This is, I think, about a week post-op, and this is about 6 weeks to 3 months. I do not agree with the fact that frontalis muscle flap produces less lag of ophthalmos than levator resection. I've seen my patients have just as much lag of ophthalmos as a levator resection would give me, but nonetheless, this is, like I mentioned, this is more of a surgery that patients demand for than what you probably might want to perform. The next one here is Mueller's muscle conjunctival resection. This is a posterior approach to correction where you are shortening the Mueller's muscle. And this is a patient with an anophthalmic ptosis, and quite surprisingly I figured that in the series of patients that we studied, Mueller's muscle performs better than levator resection in anophthalmic ptosis. Levator resection always gives significant overcorrection versus Mueller's muscle, which kind of gives you the appropriate correction and does not worsen lag of ophthalmos in these patients. So the procedure is fairly simple. You see the Putterman's clamp being used over here, into which you clamp your Mueller's muscle and conjunctiva. You decide the amount that you want to resect, and you clamp that much tissue, and you run a suture in both directions. I typically like to use Prolene. In our part of the world, we don't have catgut, but catgut is an excellent option for using in Mueller's muscle conjunctival resection as well. And then I like to exteriorize the suture and tie the suture on the skin surface, so that at 1 week or 10 days post-operative visit, I can just remove the suture. Once you've tied the suture, you resect off the amount of tissue that you had decided that you will resect, and you can see that she has almost immediate correction following Mueller's muscle conjunctival resection. This is another cited patient in whom we've performed this surgery, mild ptosis, just to symmetrize the tarsal platform show pre and post-operative. And here is yet another patient with a tarsal platform show and mild ptosis, where we've again done a Mueller's muscle conjunctival resection and had good outcomes. The last bit is the frontalis sling. Now I tend to prefer using an open sling technique, whether I'm using silicone or PTFE or fascia lata. I tend to open up the eyelid crease and fix the sling material on top of the tarsus. And I do this because epitarsal migration is one of the common causes of failure, especially when you're using silicone quite a bit. I use a pentagon technique that you're seeing over here. The initial steps of dissection again are very similar to levator resection, where you expose the superior border of the tarsus, because that's where you're going to anchor your sling. An 18 gauge needle is a perfect needle to use with the bodkin of the silicone rod. It fits into it perfectly and helps you to navigate the needle out much better. And then you pass your entire sling in the pentagon fashion like I'm showing you here. This is the epitarsal bite that you take, and then on the contralateral side, going back towards the brow, and finally coming out from the brow incision onto the central incision on the forehead. You could again play around with these incisions and have them less prominent by changing the position. You could bring the central forehead incision a little lower as well. That was the epitarsal fixation that I do with Prolene. I check the contour. If I'm getting a good contour, I go ahead and form the lid crease. So the second advantage I get with this technique is I'm able to give a good tarsal platform and form the lid crease, which otherwise doesn't happen quite nicely in patients who are having frontalis suspension. And then you just tuck the two ends of the silicone into a pocket that you've created in the forehead and close the incision. I use Vicryl typically to close the brow incision. And here's a child who's had frontalis suspension. He had amblyopia on the left side and needed surgery to correct the visual axis. And even though it's just, you know that this child is going to need a revision later on, I would still prefer to perform an open sling so that I can delay the correction as much as possible. And finally perform just another surgery when the child is about 8 or 10 years of age to give them good correction of ptosis. In summary, I've spoken to you about the 4 techniques of ptosis repair that are widely used. Levator resection, probably the commonest performed procedure, helps you symmetrize the tarsal platform and also helps you correct the eyelash contour. You can correct the lash ptosis as well. Mueller's muscle conjunctival resection works beautifully in mild ptosis, especially in anophthalmic ptosis. Frontalis suspension, my choice is to open it up and do an open sling technique and do an epitarsal fixation. And for frontalis muscle flap, like I mentioned, at this point of time, I do it purely out of patient pressure and peer pressure. I do see a lot of lag ophthalmos, and I'm not very sure if this is the surgery that's going to change how we manage ptosis in future. Thank you so much. The next talk will be by, I sort of forgot the order, Stephanie, you? Okay, Stephanie is going to take us through tips and tricks in blepharoplasty.
Hello, can you hear me? Yeah, so thank you so much, Tajani, for putting together this course and letting me be involved. So mine's a little bit different. I'm not giving an overview, but I'm giving a few cases about complications. Later on the instruction course, actually I'll be talking about Asian blepharoplasty and the complications related to it, so it's more aesthetic. Here we're going to talk a bit more about the functional complications. So Dr. Ganga always says, if you're ready to present complications, I guess it's a good thing. All right. Yeah, so I'm talking about complications. These are my disclosures, none of which are relevant to this talk. So the very first case, complications in blepharoplasty, you can group them pertaining to eyelid surgery. Any eyelid surgery, you can get hemorrhage, infection, scarring. Pertaining to blepharoplasty, we think about excessive skin or fat removal, lid retraction, over or under correction, crease issues, which we'll talk about in the later instruction course, and anything related to fat grafting. So this is my first case, my first ever and last ever, hopefully, post-op hemorrhage after a quad bleph. This was 5 years ago when I first entered private practice, and since then I've been extremely careful about hemostasis. So what we immediately went in. This was 4 hours after surgery. The nurse called me and said, "Oh, patient's going home, but the left eye looks very swollen." When she sent me the photo, I immediately rushed in. I just wish that they had updated me a bit earlier, but that's fine. So we found the vessel; it was still bleeding. We did bipolar hemostasis, careful closure and layers, and lots of hand-holding for patient and family. Thankfully, the hematoma resolved. Unfortunately, the left, she has some hemosiderin staining from the bruising, and she's got some leftosis because we'll talk about that later. I think all the tissue planes have probably been affected, some cicatrization there, but we went on to do a left eye levator plication so that there'll be more even eyelids. So let's talk about hemorrhage. I think that's probably our most dreaded complication as an eyelid surgeon, or any surgeon. It's not, so bruising by itself is not a complication so much as an expected side effect, especially for incisional blepharoplasty. The eyelid has a rich vascular supply, no matter how meticulous your surgical technique is. To minimize bruising, yes, we avoid anticoagulative drugs 7 to 10 days preoperatively with consent from the patient's prescribing physician. Control his or her hypertension. This is very important. Avoid post-op trauma, bending and straining. So, of course, during surgery, careful dissection and hemostasis. Post-op cold compressors in the initial 24 to 48 hours. Head elevation. And there's anecdotal evidence about arnica, which I do give to my patients now, and tranexamic acid, which I also do give to my patients now, systemic and local. So, but if a hemorrhage does occur after surgery, the bleeding may spread diffusely through interstitial tissues or collect as a focal preseptal hematoma. So, our patient had a preseptal hematoma. It's not usually a threat to vision, but the appearance can be a significant source of stress for patient and may lead to varying degrees of cicatrization, eyelid malposition, pigmentary disturbances, and discomfort, which our patient had. Conservative measures are usually sufficient, whether it's with cold compress or head elevation, but in her case, because it was progressing, I decided to do a surgical evacuation, although that may rarely be needed. So depending on the size, the progression, lack of response to more conservative therapy, you may lower your threshold to go in. Retrobulbar hemorrhage post-blepharoplasty is extremely rare, but all surgeons should be aware of the risk. It's a form of compartment syndrome where the orbit is bounded by 4 bony walls. The orbital septum acts as the compartment. So with an acute hemorrhage, the intraorbital pressure rises abruptly, blood supply to optic nerve is compromised. I think recognition is key, as is a rapid response. So these are the clinical signs which we're all familiar with. So what we should do is go in with a rapid release of orbital pressure by opening the wound, a lateral cantotomy and inferior cantolysis if necessary. If still no improvement, operative control of bleed, even a fracture of the orbital floor, orbital evacuation, and of course these are the adjuncts, but they should not take the place of prompt pressure release. Of course, on a more superficial level, we can reduce the bruising now with machines such as BBL to reduce the facial bruising. It does reduce the bruising quite significantly, but this is on the superficial level. So this is a patient, another case, referred over. She was so upset because she had blepharoplasty done by a plastic surgeon elsewhere, upper and lower, and you can see how aged she looks. So this is another patient done by a plastic surgeon. You can see she has significant lid retraction because too much skin has been removed. So it's very tight, the anterior lamella. So what we did is we did a skin graft for her. You can take skin graft from pre or post auricular or supraclavicular area. So this is the post auricular area. We remove an ellipse of skin. And the post-auricular area is very nice because it's not exposed to UV, and so the skin there is not sun damaged. It can also be thinned out very nicely. So and it heals very nice as the donor site. And then you just after, of course, we had released the scar tissue for her, and then try to remove most of the fat so that it's just a full thickness skin graft, and then suture it back. So the leg of thymos has reduced, but of course she'll continue to heal. So I think tissue preservation and blepharoplasty is very important. We should be conservative in skin, fat, muscle removal. It's not so much what you remove, it's what you leave behind. So do leave at least 10 to 15 millimeters between the brow and the upper incision. This is to reduce, brow ptosis and also to reduce the chance of lid retraction and lag ophthalmos. Of course, during surgery, release the scar tissue, but in cases where there's insufficient anterior lamella, then we do need to consider a skin graft. You can take skin from the fellow eye if there's excess skin, but in our patient, she had bilateral blepharoplasty done, so there wasn't excess skin in the other eye, so we took it from post-auricular and can take it from other regions as well. So again, this is another patient referred. She came in, she done by a plastic surgeon. So this is her pre-op, and then this is her post-op. And then another plastic surgeon decided to revise her within the 1 month post-op, which is not a good idea. I think anytime you see such lid retractions, injections of steroid, massage, 5FU for a few months, there's so much scar tissue and inflammation going on, you want to wait a few months before you go and do a revision. So right now I'm hand holding her. We'll be revising her in a few months time. This is another patient who we handheld, also done by a plastic surgeon elsewhere, came in with lower lid retraction, already handheld for 6 months, but you can see the right side, the lids are extremely tight, a lot of anterior lamella and posterior lamella insufficiency. So we did, for the posterior lamella, we did a donor sclera, and then for the anterior lamella, we did not only a cantoplasty, but we also did a skin graft for her, as we showed in the previous video how to do a skin graft. Okay, next, another case referred by a plastic surgeon because the patient had revision 3 times, but you can see she's very unhappy with the left eye, multiple adhesions. So at first I attempted filler injection, but it didn't help. So this required open access to release all that scar tissue, and because she has not enough fat left, we decided to do a dermis fat graft. I heard Rohit talked about this in his keynote yesterday. So we did a dermis fat graft and sutured it to the superior sulcus and anchored it to the orbicularis. So hopefully this prevented the adhesions and gave the volume she needed. So just a bit of lid retraction there, although we didn't really touch the levator, but she's happy that those adhesions have been released. So I think in terms of scarring and adhesions, how we avoid it is really by avoiding overzealous soft tissue or fat removal and blepharoplasty, because these create adhesions. If that crease is shallow, we can attempt fat or filler injection alone, to bolster the skin and prevent further progression of that crease. However, in most cases, open access is required. So you do need meticulous release of the adhesions between the levator and the orbital septum, and between the post-orbicularis fascia and the orbital septum. And then to prevent re-adhesion, you can inferiorly displace a well-organized septum and orbital fat between the orbicularis oculi and levator, or if the patient has no more fat because too much fat has been removed previously, then you can do fat grafting or a dermis fat graft, like in our patient's case. So case 5. This patient had undergone upper blepharoplasty in Korea, but she was also convinced by the surgeon that she was hollow in the lower lid, so to undergo fat grafting in the lower lids. But you can see she has an unsightly bulge in her right lower lids, which she never had before, so she was very unhappy about it, and she wanted it addressed. So what we did is, through a transconjunctival approach, we opened up and tried to remove the fat that was grafted. I think the problem is the surgeon had probably grafted microfat instead of nanofat, so it resulted in that pseudo eye bag appearance. So this was all the fat pieces that were removed through the transconjunctival approach. So post-op, she's doing well, and she's very happy that that unwanted grafted fat has been removed. So I think fat grafting is becoming increasingly common overseas and also among surgeons in Singapore. There are complications related to autogenous fat injection to the eyelids because the eyelid skin is so thin. There may be visible lumps or nodules, or if inflammation continues, there may be granulomas, which may require surgical excision. Of course, with fat, there's also a risk of vascular occlusion, and the results may be unpredictable. So do take extra care for fat grafting in the eyelids. Like we mentioned microfat for volumization. You can use beneath that tear-trial ligament in the cheeks. But for the thin skin above that tear-trial ligament, you probably can only use nanofat, or you can use other injectables available in the market right now. So this is just a summary. I think complications of blepharoplasty is not uncommon. We can reduce them with meticulous technique, careful hemostasis, respect and preserve the soft tissues. And to manage them, be familiar with anatomy, especially for revision surgery. Grafts and flaps are your friends in tissue loss. And yeah, thank you. So.
Thank you very much, Stephanie. We'll move on with Raghu's talk on eye socket. It's all about the base, tackling complications of the orbital spherical implant.
Good. Thank you everyone for turning up for the first session of the day, and thanks Rajni for inviting me to be part of the IC. So I'll be talking about socket complications, some of my cases and some from others, as always happens. So this is how it was in 1848 when this is almost like a subtotal exenteration without anesthesia. So this is almost stayed the same up to about 265 years after 1848. So only in the second half of the 19th century we actually moved on to do enucleations and in a systematic manner. So earliest evidence of enucleations are like early Egyptians during mummification would remove the eyes and fill it up with the orbit with wax and precious stones to simulate the iris. And there is some evidence that around 500 BC, Egyptians and Roman priests made clay prostheses to be worn on disfigured globes. The clay prosthesis was attached to a ball of cloth, and it's similar to size of an empty socket, and painted and held in place with a thong. So no records to show how enucleations were performed at that time, but we gradually progressed to what we now do, enucleation or evisceration with different implants. So an ophthalmic socket. So what is the purpose of reconstructing a socket? Is basically removal of an eye and the subsequent management of the socket, and it needs a close collaboration between the surgeon as well as the ocularist, because it's good to have a good trained ocularists, so that they understand what is required of a particular socket, and they give the feedback to the surgeons to what is to be required. So so goals of enucleation or evisceration is a healthy and a comfortable socket free of discharge, which can be fitted with a well fitting stable ocular processes that mimics the fellow eye in appearance and movement as far as possible. It's never going to be 100%, but as far as possible. A symmetrical appearance without any enophthalmos or an upper eyelid sulcus deformity, and an absence of a upper or lower lid malposition, and a normal eyelid closure over a ocular process, because the patient wants to be seem normal whenever he's talking to somebody and blinking. So indications for enucleation evisceration, it has been the same for many decades now. Painful blind eye following a failed retinal detachment surgery, or a rubeotic glaucoma, or anterior staphyloma, all those things are indications. A blind unsightly eye, they want it for a cosmetic correction, or an intraocular tumor like retinoblastoma or a choroidal melanoma, where that is the only play, so that will actually give the patient a cure for the disease. And severe irreparable trauma in ocular trauma, as far as possible we try to retain the eye because of the psychological reasons for it, but if it is unsalvageable, then it is better to do a evisceration at same sitting and go ahead with the thing. So the concept of post-enucleation evisceration socket syndrome. So basically, about 2 to 3 decades ago, they were not putting in implants when they're putting in the in children, when they were removing the enucleating the eyes. They were not putting in the implants. So what that does is, it over time, if you put a prosthesis over this empty socket, there would be a deepening of the upper eyelid sulcus, variable amounts of upper eyelid dysfunction like a lag ophthalmos, a severe ptosis, and stretching of the lower lid, because as you can see in the schematic diagram here, that it is pushing the lower lid down. So the stretching of the lower lid, and then finally ectropion develops, and that further reduces the fornix, and then sets up a vicious cycle of that, and then the socket is no longer able to hold the prosthesis there. So I just want to give a, like, what all complications can happen during the during these cases. So this is a case that we had. It was a panophthalmitis, and we did and it was painful blind eye, and we did a evisceration with implant. But about 2 weeks out, she still had the schemosis, and the conformer that we had put was not holding up. So what we did was we put a phonics forming sutures so that the chemosis would drain out, and then finally she was ready for a permanent ocular prosthesis. Uh, there's this patient also, she had a post enucleation socket syndrome. She had a road traffic accident with a avulsion injury of the lower lid, and the lower lid was reconstructed. They removed the eyeball, but they did not put a implant at that time. And then they put a prosthesis over an empty socket that caused her the whatever I described in the previous slides. So basically, there is volume loss and the inferior phonics shortening, and the prosthesis was not holding up. So and she was very upset with the way it was looking. And then so what we did was we put in the implant and then used phonics forming sutures, and also tightened the lower lid, because the lower lid was an avulsion injury, so it was sagging down. So even tightened lateral tarsal strip procedure was done, and we tightened the lower lid as well. And as you can see, we have a reasonably symmetrical look on both sides. So this patient was from an overseas patient who came, who had a post bevacizumab injection, panophthalmitis, and he was in extreme pain. So we went ahead and did the did the evisceration, and after about a week post the evisceration, the infection the conjunctiva was not very healthy, and that was getting reinfected. So we had to go in for a debridement every 3 days, so that the slough would go, and then we were treating it topically as well. And but eventually there was no extrusion, because there was basically the tissues, the sclera, as well as the scleral melting happening, and as well as the conjunctiva was not very healthy. So that's the reason why it was not healing. So basically we had to do a little hand holding, and we couldn't remove the tumor, remove the implant, because the patient was from overseas, so we didn't know how the patient would, whether the patient would be able to come back or not. But eventually it settled down, and we could put a full size prosthesis and reasonably good symmetry. So this is another patient who did not have a implant put at when he was a kid. He had a retinoblastoma, post retinoblastoma. He had a radiation as well, and is a severely contracted socket. And he did not have implant, and no prosthesis would fit there, because there's a severe ectropion as well. So initially we thought the best thing for both the volume as well as the surface reconstruction is basically a dermis fat graft, which would give some surface as well along with the volume. So we did the first procedure thinking that it would be the one procedure that would be required, and did a phonics forming sutures for both the upper and lower eyelids, lower phonics. And but the problem was that it was the lower fornix was not enough, and then we had to do a second surgery at a later stage to do a mucous membrane grafting. And so you can see the graft that is put in the lower lid, and we did that. Sorry. So this is after the surgery, after about 3-4 months after the first surgery. We could put a reasonably sized prosthesis, which is good, giving good symmetry. He also had nystagmus and other things as well. So it was a little challenging, but our ocularist did a very good job of putting a good prosthesis. So this is the first time I had seen such a case in my life. So I've never seen this ever. So there was this 27-year-old man who came with an infected socket with a foul-smelling mucopurulent discharge. But his main issue was not the discharge or the foul-smelling mucopurulent. His main thing was cosmetically it was not looking good. He's 27 years old, so I can understand why that is the most pressing problem. And he's had a history of multiple surgeries, and the last one about 10 years back when he was about 17 years. So the history was that he had retinoblastoma, and they did a right eye enucleation at the age of 3, but they did not put an implant at that age. And when he was around 14, they put a secondary orbital implantation, Then after that, there was exposure of that implant, and it was treated with a fixed prosthesis on top of it. They basically sutured the prosthesis over the conjunctiva, over the exposure, to close the exposure. Instead of treating the exposure, they did a shortcut. And then because it was not there was a lot of volume loss, and they put an additional prosthesis on top of the existing prosthesis. So he had like a double decker prosthesis on top. So then we took him up for surgery. It was a very messy surgery. It took almost an hour to take out the whatever implant that they had put inside. It was, I think, it was difficult to say what it was, but I had to take it piecemeal. It most likely was a porous PMMA, and there is a lot of ingrowth into the vascular ingrowth into the implant, and it was a very messy surgery. It took about 1.5 hours just to take out everything that was there. So at that point of time, I did not put any implant. I just waited for the socket to heal. So this is what we removed at the end. There were many smaller pieces which we couldn't salvage toward the thing, and I put it for the so it came out to be a MRSA, the organism that was growing in the socket. So once the socket settled down for about 4 to 6 weeks later, we went in, because the volume correction had to be done, and we couldn't put a large enough implant, and there was severely contracted socket, so there is a lot of scarring within the Tenon's capsule. So even if you put a big implant, it will not stay. So what we decided was we'll put an inophthalmic wedge, and we put a smaller implant than what we would usually put in a new socket. So this is inophthalmic wedge. So we put the inophthalmic wedge below the periorbita, and to increase the volume, and then we put a little smaller implant. I think this was a 16 millimeter implant. So implant, so that we then after that we put a mucous membrane grafting for the lower lid, the surface augmentation, and for phonics forming sutures for both upper as well as lower phonics. So this is about 3 months out after the first surgery. So he got a reasonably, and he's pretty happy about the process. And the movement is not that good because of course there is so much scarring, but at least when he's looking straight, he's fine. So this is another case which I had done enucleation about a year before this for retinoblastoma. So her main complaint was that the ocularist actually told me that I am not able to fit in a good prosthesis for this patient because it's moving sideways. So when we remove the implant, we see that you can see that the lateral fornix is very deep, and when we did the imaging, we see that it is moved medially. So I think I have two, three more slides. So it's moved medially. So when we moved medially, what we decided was that if we remove the implant and put it in the right place, it will again go back to the same place, because wherever there is least resistance, it will go back to the same place. So again, in this case, we put a inophthalmic wedge, which would push the implant to laterally, because the thickness is more on the medial side. So this comes in the right as well as the left inophthalmic wedge. So we put a right inophthalmic wedge into the implant so that it pushes the implant laterally. And sure enough, with that we could put a reasonably, we could get that processes in the alignment correctly because of that. So this is another case where he had a painful blind eye because of glaucoma, absolute glaucoma, and we did a surgery, and it was fairly uneventful. Nothing happened. Patient was very happy, and 2 weeks later he had staining at stools, and then he came to the OPD with outpatient clinic like this. So it is about, and it's sudden. It was not there the previous day. It is because of the staining in stool. So he had this. He was putting pressure on that, and it just bled. And he was not even on blood thinners or anything, but that's what he came with. And then we see that we did the imaging. We can see that the implant has been is very anterior, and there is a retro implant hemorrhage. There's a hemorrhage at the back. So then we had to open him up, and then you had to open it up and take out the blood. So this is just a few weeks back. So I don't have the post-op outcome. So basically it's there is a implant hemorrhage at the back. So take home message is basically secondary socket reconstructions are challenging but can be satisfying if you do it in a very stepwise manner, and volume correction as well as surface augmentation is required. Initially I wanted to do everything at one stage, but I have I have do more and more of these sockets, I realized that stage procedures is very important. You do one step at a time because the variables are reduced, and then managing the patient expectation is also very important because they come with after a lot of surgeries, and they think they want to get back to how they were before, and it is very difficult sometimes to their expectations are very high. So we have to manage them and tell them about what all things can what all things to expect and post surgery, so that the post surgery recovery is better taken care of. Thank you very much.
Thank you very much, Raghu. We'll take the next talk by Hosok Sa from Asan Medical Center, Korea. He'll be talking to us on management of failed DCRs and his technique of revision.
Thank you for the kind introduction. So it's my honor to be part of this session. Yeah. Yeah. Okay. So I'm going to talk about revision endoscopic DCR. As you all know, DCR is the standard treatment for complete NLDO. Yeah. Showing a high success rate. However, 5 to 10% of cases, we need perform the revision DCR. For revision DCR, endoscopic endonasal approach is very useful as it allows for comprehensive assessment of failure causes and targeted surgery. Ideal ostium after DCR can be achieved by muscularizing the entire lacrimal sac, but in reality, it's not always easy to perform. There are many causes of DCR failure, and ostium scarring is the most common one. And membranous scarring can be formed over the ostium, or thick ostium scarring would be more common. Inadequate bone removal can result in high ostium causing some syndrome or small ostium. Now, other causes include distal canalicular obstruction or soft tissue obstruction by middle turbinate or polyp. Not surprisingly, there are many cases which are associated with multiple causes. So revision endoscopic DCR have to address many issues, including the scar and granulation tissue at the ostium and inadequate size or location of the osteotomy. So ostium scarring and osteotomy will be the most important essence for revision DCR. Revision DCR is usually very challenging because of distorted anatomy, difficulty in separation, and intranasal adhesions and increased bleeding risk. For successful surgery, it's important to evaluate the obstruction type, and obstruction pattern could be related with bony obstruction or scarring or combination. And for evaluation, preoperatively, DCG, CT, or CT DCG can be performed. And CT is useful to observe the osteotomy site. In this particular case, the lacrimal sac is still covered by lacrimal bone posteriorly, so it should be addressed. And DCG is important to see the obstruction, especially scarring pattern. So when there is pulling inside of the lacrimal sac, you can think about the possibility of membranous obstruction. But when there is no pulling inside of the lacrimal sac, you should suspect the possibility of common canalicula obstruction or thick ostium scarring. CT DCG could be very useful, which can address the osteotomy site and ostium scarring at the same time. Intraoperatively, lacrimal sac mapping is important to see the obstruction type, especially 45-degree up and down test is useful. And lacrimal probe is inserted in, through the canaliculus, and it can be angled 45-degree up and down, which correspond to the lacrimal sac or ideal ostium site. So when you encounter the bone obstruction, you have to do more osteotomy. When you encounter the soft tissue obstruction, so ostium scarring should be removed. The cicatrix should be excised around the internal common canalicular opening while preserving healthy sac mucosa around the CC opening. And flap suture technique is useful to reduce the granulation tissue formation or scar contracture. So you should enlarge the osteotomy site, and mitomycin C could be helpful for cases with thick ostium scarring. Adequate nasal packing is another important thing. And for cases of canalicular blockage, trepanation or serial dilatation is helpful. And silicone stenting should be performed all the time. And double stenting could be beneficial to maintain the patency of canaliculus. Synechial should be performed. And partial middle turbinectomy or nasal septoplasty could be useful, but not always required. So I'm going to share some cases, and this patient was reported for revision DCL. When you see the CT DCG finding, so you can see the thick ostium scarring here, and when it comes to osteotomy site, the size is not bad, but inferiorly there is an inadequate osteotomy site, which should be addressed. And there is a small spot or small space in the lacrimal sac which suggests some amount of healthy tissue inside of the lacrimal sac. During the surgery, you can see a very small ostium at the operculum of the middle turbinate, and after local injection, so lacrimal probe is inserted for lacrimal sac mapping. You can see the level of the common canalicular opening. I usually use a monopolar cautery for nasal mucosa incision to reduce the bleeding during surgery. And it should be about 5 millimeters above the common canalicular opening level. And nasal mucosa, which correspond to entire lacrimal sac, should be incised. And using a Freer elevator, the nasal mucosa is raised and exposing the lacrimal sac inside. And while the lacrimal sac is tented using a lacrimal probe, I usually use a keratome to make a vertical incision to expose the inside of the lacrimal sac. As the patient has a thick ostium scarring, using a keratome or cutting ethmoid, the thick ostium scarring can be removed appropriately. Then we decide to perform the flap suture technique to reduce the scar contracture after revision DCL. So this technique might be challenging at first, but with practice you can do this technique without any special instrument. And the posterior flap of the lacrimal sac is sutured to the nasal mucosa to make her wound healing clear. And you can see the small amount of healthy tissue, healthy mucosal tissue inside of the lacrimal sac. And inferior osteotomy is enlarged. And the inferior site inferior portion of the lacrimal sac is completely exposed, and silicone tube is inserted. And as this case is related to the thick ostium scarring, we apply the mitomycin C for 3 to 4 minutes, followed by saline irrigation. Lastly, the nasal packing material, which is soaked in gentamicin and triamcinolone steroid, is inserted for packing. So moving on to another case, this lady was referred for the revision DCL. So when you see the CT scan, CT DCG, you can see the contrast pooling inside of the lacrimal sac, which correspond to the DCG finding, which suggests the possibility of membranous obstruction over the ostium. And you can see the thick synechiae between ostium and nasal septum. So we have to address this issue as well. So during surgery, as shown in the CT scan, you can see a thick synechiae between ostium and nasal septum. And using a free air elevator, the synechiolysis is performed, and the nasal septum is medialized to secure the enough space around the ostium. And after packing, you can see the ostium site well, and lacrimal probe is inserted for lacrimal sac mapping. Suggesting the membranous obstruction. And again, monopolar cautery is used to make an incision on the nasal mucosa to cover the entire extent of the lacrimal sac. Using a free air elevator, the nasal mucosa is raised to expose the inside of the lacrimal sac. And while the lacrimal sac is tented using a probe, so keratomy is used to make a vertical incision, you can see the enough amount of healthy mucosa inside of the lacrimal sac. And using a blade and ethmoid forceps, the thick synechiae is removed. And the osteotomy site is enlarged superiorly using a kerosene plunger and power drill. And after that, you can see the inside of the lacrimal sac as well as common canalicular opening. And silicone stent is inserted and inferior flap was made. And lastly, the packing material is inserted, which will be maintained at least 2 weeks to prevent the reformation of the synechia. In conclusion, there are many causes of DCL failure, and ostium scarring and inadequate osteotomy is most important. And for successful surgery, the cicatrix should be completely excised while preserving healthy sac mucosa, and flap suture technique is helpful. And osteotomy site is enlarged enough, and internal CC opening should be proper, and scarring and contracture can be prevented using many methods, including MMC, nasal packing, and postoperative care. Thank you very much for your attention, and I'd like to invite all of you to AP Supper's masterclass. Thank you.
And we'll take the next talk on patient-specific implants and orbital reconstruction. So thank you once again for being here this morning. I'm Tarjini Dave. I work at LV Prasad Eye Institute in Hyderabad. I have no financial disclosures to make pertinent to this talk, and I do have consent for the display of photographs of my patients. I'll take you through what patient-specific implants are, the advantages that they have, a little bit on virtual planning of these implants, and what are the widely used materials at this point of time. So that was a reality check on height after Hosoksas presented. All right, so some indications of patient-specific implants like congenital defects or tumors, trauma and infections, where we could use them. Most of these are in secondary reconstructions, and then conclude the talk. The orbit, like we know, has a very complex three-dimensional structure, and there are a lot of functional consequences of orbital and soft tissue trauma. There also are aesthetic implications from orbital trauma. And what has changed in the past decade is the availability of better quality imaging, especially the DICOM data that is available from CT scans for treatment planning. You also have to your access navigation or image guided surgery and real-time intraoperative imaging that can help you give better outcomes to your patients. With all of these technologic advancements, there's also been an advancement in the field of implants that are available for orbital reconstruction, and patient-specific implants are such bespoke implants that are individual to a patient and a defect. You can see over here is a couple of implants crafted for an orbit which is much enlarged compared to the other side, and there is a defect in the greater wing of the sphenoid. This is a patient with a plexiform neurofibroma that also has a meningoencephalocele into the orbit and is producing a pulsatile proptosis. While soft tissue debulking with the several techniques that are available does help, pulsatile proptosis is actually an issue that needs to be kind of managed by creating an implant that will bridge that gaping hole in the greater wing of the sphenoid, and that can only be done by implants which are individualized to the defect, and this is what essentially a patient-specific implant can do. The advantages here are that these implants offer you a higher accuracy of correction because you've spent a lot of time before the surgery planning what the shape and size of the implant should be, what its contour should be, and hence as you slip it into the defect you have much better site adaptation and you don't need a lot of intraoperative tweaking. This also reduces your surgery time and certainly gives you better post-operative results in select cases where your run-of-the-mill implants will not give you the correction that you're looking for. Generally, these implants are available in a variety of thicknesses, but the commonly used ones are around 1 millimeter thickness, especially the titanium implants are 1 to 2 millimeters in thickness. This is a relatively thick implant. You can tweak around with the thickness if you're using different kinds of material. What is the virtual planning that I was talking about? So essentially what you do in this step is you want to normalize the orbit. So if it's just one orbit that's involved, you already have the contralateral orbit for reference, and that's used as a template and is projected onto the abnormal orbit, and then you bridge the areas wherever there is a defect. For instance, here an implant has been crafted to sit in on the lateral wall of the orbit in that same patient with plexiform neurofibroma that I mentioned. Along with this, you can see that the right side orbit also has an increase in the vertical dimension of the orbital aperture, and that is also corrected by symmetrizing the orbital aperture to the contralateral side. So all of this can be used by or done by readily available online softwares, and there are several companies that can help you do this kind of planning. For instance, here's a case of trauma that you can see has been corrected, but there's absolutely no bone here. There's just an implant holding a small bit of the zygoma to the frontal bone and absolutely no floor or maxilla, and that's just been bridged with the help of a mini plate here. And this patient obviously had soft tissue consequences as well. So what was required for him is to have the facial skeleton normalized and the orbital volume also normalized, and that's where you can create such bespoke implants that are unique to a defect and a patient. The good part about these steps of virtual planning is that you can actually see what the orbital volume on the contralateral side is, and then can try and symmetrize it on the affected side. For that, if you have to raise the posterior end of the plate that goes on the floor of the orbit, you could go ahead and do that. Or if there's any other change that you want to make, you're free to do that, and even try it on a model of the patient's skull that is printed before you actually try it on the patient during surgery. The materials that are available are largely titanium, polyethyl ether ketone PEEK, porous polyethylene. Also, these days, bioresorbable implants like polycaprolacton are available for you to craft as a patient-specific implant. Titanium is a rigid implant and gives excellent structural stability, but if that patient-specific implant needs further contouring intraoperatively, it's very difficult with titanium. That's one disadvantage, and this exactly becomes the advantage of a porous polyethylene or a PEEK or an osteomesh or resorbable implant when crafted as a patient-specific implant. So with this little background, the indications essentially at this point of time remain very irregular orbital defects for which you do not have a run-of-the-mill implant available, and defects where you have multiple walls of the orbit that are fractured, which you think will not fit back into position. Possibly if you have loss of bone for any reason, and in situations where you're performing revision surgery for residual defects, these are the cases where you would want to go ahead and craft a patient-specific implant. I'll show you some patient examples here. This is a lady who has a maxillary sinus ossifying fibroma that also involved the orbit, and she had a complete excision, but then it leaves her with a defect where she's lost the entire maxilla, she's lost her upper jaw, she's also lost the floor of the orbit in order to completely remove the tumor. And what we were able to do for her in a primary sitting is to craft an implant that gives her back the orbital floor, the maxilla, and also gives her the potential to have osteointegration to get new permanent teeth in her upper jaw. And all of this would not be possible by using standard implants. This is how her skull model and the implant looked, and that's her radiology post-operative. And this is her post-operative. You can see that little faint scar along the nose. She certainly had an excellent outcome with the reconstruction. Here's the lady who I've been showing you earlier with the plexiform neurofibroma. She had debulking of the soft tissue, but she had significant hypoglobus and pulsatile proptosis, and we were able to reduce that hypoglobus and pulsatile proptosis with the help of these implants. She still needs some soft tissue work, but nonetheless, if you look at her bony skeleton, we've been able to give her back the orbital rim that had receded, as well as the lateral wall, which pushed the brain back and sort of reduced the proptosis post-operatively. Here's another gentleman who had congenital hemifacial hypoplasia, where again the bony skeleton has been corrected with the help of these patient-specific implants to improve the projection of the face, and over that he has a prosthetic eye. Compared to the preoperative picture, you can see that the hollowing has settled down much better. Here's another gentleman who had a bear attack, and on the right side he has secondary nasolacrimal duct obstruction, for which we performed a DCR. But what was of interest is during the primary intervention that he had, the eyelids were completely closed in a blepharopathy, and he was living like this for the past 20 years. He did tell us that he had good vision before the blepharopathy, and he wanted to explore the possibility of opening up his eyelids and seeing if he was able to see again. This is how his facial skeleton looked. There was significant loss of bone all around the orbit, and we crafted an implant for him, because if you have an eyeball which is open but no support for it, obviously there'll be exposure keratopathy. And we opened up the blepharophy, did a mucous membrane graft for the posterior lamina to keep the eyelid separate from the ocular surface, and also reconstructed the orbit with the help of this patient-specific implant. He did see, he had about 2200 vision, with that he did quite well with his blepharophy. This is yet another patient who had mucormycosis, and I treated him during the active epidemic of mucormycosis that we had in India during COVID. We were able to spare his eye, his vision. He had 20/20 vision, but then from the mucormycosis, he developed osteomyelitis, for which he required debridement of bone, which was also done. And this is how his bony skeleton looked, and he was dependent on this tarsorrhaphy because there was now no support for the eyeball inferiorly, since we had debrided this bone. We were not able to release the tarsorrhaphy, and he was very keen to have his orbital aperture normalized. And 5 years after his debridement, we planned a patient-specific implant, and this is how his implant sits. Over a period of time, we were able to wean him off his tarsorrhaphy, but then I saw exposure of the titanium implant. So this again is a situation where I've burnt my hands, and I've learned that in situations where your overlying skin cover is compromised, if your subcutaneous tissue is not adequate, you probably want to be very, very careful in using patient-specific implants. Here is another patient with mucormycosis who actually over a period of time did very well, a very similar presentation to the previous one, where we placed the implant and it sits there beautifully. He's had almost a 5 or 6 year follow-up now. This is how his implant was fabricated, and this is him about 5 or 6 years later, having good support to the lower eyelid and no exposure symptoms at all. This, unlike the previous patient, is a situation where we had very good soft tissue cover, and therefore there was nothing to worry about in terms of exposure. In conclusion, I've spoken to you about what patient-specific implants are, the indications for planning, and certain case situations where you should use it, with a little bit on situations where you should be wary of using such implants. Thank you so much. We'll now have Anasua Ganguly, who's the head of the Kode Venkatadri Chaudhary campus of LV Prasad Eye Institute in Vijayawada, speak to us about taming the flame in ocular oncology.
Good morning, everyone. Thank you, Tarjini, for this opportunity. So, in the next few minutes, I will be taking you through my through few cases and my rescue measures in each of these cases. First, I will begin with eyelid tumors. So this particular girl, 6 years old, had come to us with a right eye ocular surface squamous neoplasia with an intraocular extension. You can see we had to do enucleation, and that's a customized ocular processes in the right eye. But the problem we were constantly facing was the multiple crops of squamous cell carcinoma on her face, because this was a patient of xeroderma pigmentosum, and multiple times skin graft has been done, and as you can see from the edges of the skin graft area, new lesions were cropping up. So in this particular case, we resorted to imiquimod once daily for 2 months, and this is after 2 months. It was taking care of all the squamous cell carcinomas which were cropping up. So topical imiquimod is a good option for multiple superficial squamous cell carcinoma and basal cell carcinoma. Apart from this, there are other options like 5-fluorouracil, photodynamic therapy, and targeted therapy. Worldwide, Vismodegib and Sonidegib has come up as a great medication for unresectable or metastatic basal cell carcinoma, but in our country the use is limited because of the expense and the fact that there is recurrence on stoppage of the medication. So neoadjuvant chemotherapy for eyelid tumors, earlier for sebaceous gland carcinoma with orbital extension, the only thing in our armamentarium was performing an orbital exenteration, but now that is not the case. Like you can see for this sebaceous gland carcinoma with the orbital extent, there's a fairly established protocol for neoadjuvant chemotherapy using cisplatin and 5-fluorouracil 6 cycles, where we chemo reduce the tumor size, and following which conservative eyelid sparing surgery is possible. So chemo reduction helps in performing conservative surgery in extensive sebaceous gland carcinoma. MAP biopsy earlier, as you all know, pagatoid spread can happen in sebaceous gland carcinoma. Earlier we used to do MAP biopsy only in cases where there were clinical indicators like diffuse conjunctival congestion, thickening of eyelid, loss of meibomian gland architecture, loss of eyelashes, surface telangiectasia. Then only we used to go ahead with MAP biopsy, but recent literature from our institute shows that we will miss 10% of pagatoid spread if we just base on clinical diagnosis. So MAP biopsy should be ideally performed in all cases of periocular sebaceous gland carcinoma. So post-operative protocol for eyelid tumors is of absolute importance. It is not just about excising the tumor. We need to look in the histopathology report, we need to look for risk factors like perineural, intraneural invasion, vascular emboli, and if they're present, we need to consider radiotherapy. Fixed frozen mismatch can happen, and in literature reported to be around 2 to 10%. So post reconstruction, if you see the margin is positive, in lamellar cases consider cryotherapy. For full thickness cases, external beam radiotherapy is required. Similarly, for MAP biopsy positivity, based on the number of sites which are involved, topical mitomycin C, cryotherapy, and for diffuse involvement, exenteration is the treatment. Regional lymph node metastasis, all cases are local lymph node examination needs to be done, and if it is positive, FNSC needs to be done, diagnosis to be confirmed, and radical node dissection and radiotherapy needs to be considered. Moving on to ocular surface tumor, nodulo-ulcerative OSSN is a very rare form of OSSN, but very aggressive. I will like to take you all through this particular case of a 28-year-old gentleman who presented to his ophthalmologist and was diagnosed as a case of limbal stem cell deficiency post chemical injury. He was started on topical steroid. This is at day 21. You can see there is a sterile scleral melt. His ophthalmologist performed a scleral patch graft, which eventually melted, and on day 28 he was referred to our ocular oncology clinic. So this is a typical case of nodulo-ulcerative OSSN. You can see the localized area of conjunctival and scleral dehiscence. Focus on the conjunctiva surrounding it. You can see that it is indurated, has these feeder vessels, and there is usually a corneal haze in the surrounding cornea. So the patient was advised extended enucleation at this stage, but he refused because the vision at that point of time was 20/25, and you can see what has happened at 10 months. The mass is engulfing the entire globe, the orbit. This is at 2 years, and we lost him after this. So this was a seropositive patient with nodulo-ulcerative OSSN, so localized ulceration of conjunctiva, sclera tarsus surrounded by indurated thickened conjunctiva. Think of nodulo-ulcerative OSSN, and an extended enucleation will be your rescue measure in such cases. So laser photocoagulation of conjunctival, benign conjunctival tumors is also something coming up. Like we have a protocol of doing a laser with the help of a yellow laser photocoagulation. And this is how visual changes happen. So this was the first patient we had done in an anophthalmic socket for a patient of nevus. And it first becomes the visual change is graying, followed by cavitation, blackening. At this stage, it can nicely be removed with the help of a bud. So this is a patient you can see without any scarring or tissue dragging, which are cases for such big tumors. In cases of surgical excision, the tumor has resolved. Plaque brachytherapy for conjunctival tumors. This was a typical case of a leiomyosarcoma conjunctiva. You can see the vascular tumor with blood vessel dragging. This is on UBM. So post-excision, plaque brachytherapy needs to be considered for all such malignant lesion to decrease the chances of recurrence. Similarly, for OSSN, of all cases where there is a base involvement, look like this particular case, you can see there was scleral fixity on clinical examination, and on UBM it shows that the anterior scleral fibers are involved. We did a lamellar sclerectomy, but that needs to be followed up. You can see the base positivity on histopathology, so it needs to be followed up with a plaque brachytherapy. So this was a secondary plaque brachytherapy, but plaque brachytherapy can also be considered as a primary treatment. Moving on to ORBIT. Bleomycin sclerotherapy. So this 12-year-old girl with an acute exacerbation of her URTI presented with this picture. So on CT scan, you can see the ill-defined multiple cystic masses, which is transcompartmental with multiple air fluid level. This is nothing but a venolymphatic malformation, and aspiration of the blood with bleomycin sclerotherapy is the treatment of choice, and this is post-op. So sudden intraorbital hemorrhage in a child, think of a venolymphatic malformation and consider bleomycin sclerotherapy. This 57-year-old lady presented to our clinic with this inferior palpable mass. There was choroidal folds, tortuous vessels. In MRI, you can see the multiple flow voids, the huge vessels which are there all around. So we reviewed the previous record, and what came up was that the patient has already undergone an orbitotomy. With torrential bleeding, the surgery was abandoned despite attempt by the surgeon using everything possible. The surgery was abandoned, and on incision biopsy, this was a case of a solitary fibrous tumor. So we have a hypervascular solitary fibrous tumor causing mass effect. We know that there has been an attempted surgical excision which can cause a malignant transformation and increase chances of recurrence. So what were the options? Options were two, either a radiotherapy or an embolization. We chose embolization because it is more targeted, saves time, and immediate surgery can be performed. So this is the embolization, where we embolize the feeder vessels, and you can see the vascularity of the tumor coming down, and we perform the surgery after 1 week, and the tumor could be taken out in toto, and this is at 5-year follow-up. So preoperative embolization in collaboration with your interventional radiologist is a safe and effective procedure for reducing vascularity in vascular tumors like SFT or alveolar soft part sarcoma. So as was being mentioned by Stephanie, you should always be very proactive in publishing your complication. This was one such patient. It was an uneventful surgery, an intraconal mass, just a cryo extraction by an inferior transconjunctival approach. But on day 1 post-op, there was no PL vision, and it was an ophthalmic artery occlusion which happened. So keeping this in mind in this context, I will like to discuss this 39-year-old lady who came to us with both eyes, best character visual acuity of 20/20, but she complained of a mild blurring in the left eye. And you can see this enhancing small mass lesion sitting on her optic nerve, causing this disc edema. So there is a lot of literature that talks about stereotactic radiotherapy for such cavernous hemangioma. So stereotactic radiotherapy has made it very safe these days. Proton beam radiotherapy will be the best option, but the availability is an issue, and also it's very expensive. So earlier days, there used to be invasive BRW frames for fixing the head of the patient. Then we moved on to non-invasive GTC frame. But at present, the brain aquaplast, which is nothing but just a cover on the face of the patient, and the onboard imaging, things are easy, and precise localization of the tumor can be done with no incision, no anesthesia. So this is what we did for our patient IMRT, and this is post IMRT. You can see that the widening of the blind spot and the superior field defect which was there has come down, and this is the optic disc edema has also resolved. So for apical tumors, intraconal tumors, stereotactic radiotherapy is a great option. You need to have a good rapport with your radio-oncologist. And this was my rescue measure for this particular patient. So combined orbital and endoscopic approach needs to be considered for all cases of orbital tumor with a or a sinus tumor with orbital extension, like we did for this particular patient, non-keratinizing squamous cell carcinoma of the maxillary sinus. Moving on to intraocular malignancy, intraarterial chemotherapy, the advent in 2000, late 2000, this has been again a game changer. It is an established technique, though expensive for us. Globally, it has become the standard of care, but for us, we reserve it for refractory cases because of the expense. However, it does not take into consideration the systemic micrometastasis, and the complications can be devastating if not done by experienced people, like ophthalmic artery occlusion. So this is the protocol. We use a 3-drug regimen, topotecan, melphalan, carboplatin. This was the first we did in our part of the country, and what I want to emphasize here is it's a collaboration between the interventional radiologist and your pediatric oncologist. And I will skip the technique there. So we basically go in through the femoral artery, and it's a super selective ophthalmic artery. We go to the ostium of the ophthalmic artery, and the drug is delivered there. So this is this was a primary IAC post 3 cycles complete resolution. Intravitreal chemotherapy, again I will skip the procedure there. So earlier the traditional teaching has been we should never go inside an eye with retinoblastoma, but again a game changer there. Nowadays we take care of the vitreous seeds with the help of intravitreal chemotherapy. We have a protocol for safety enhanced intravitreal chemotherapy where we choose cases where the retinal tumor has been taken care of or it has become smaller, so that we have a safe area surrounding the aura where we can go in without puncturing the tumor. So choose a safe side, use a thin gauge needle, preferably a 30 gauge needle. The exit should be through a ice of cryotherapy, and we need to inject the site. A triple freeze thaw cryotherapy needs to be done. Death by water, you just flush the area of the injection with the help of distilled water to flush away the tumor cells. You can also raise a bleb of subconjunctival topotecan at the injection site to take care of any tumor cells there. Earlier we used to use intravitreal melphalan, but the complications were higher, and the major concern was retinal toxicity. There were pigmentary retinopathy happening in all such patients. Now we have moved to intravitreal topotecan, which doesn't have retinal toxicity, and the efficiency is more. So this particular girl, 2-year-old, the left eye was enucleated because of group E retinoblastoma. Right eye, this is the only seeing eye of the patient. We had already done 12 cycles of high dose intravenous chemotherapy and also orbital EVRT. She presents back with a tumor recurrence. What do we do now? So intraarterial chemotherapy was our rescue measure. Again, after 3 cycles of intraarterial chemotherapy, she has some residual vitreous seeds. We resort to intravitreal chemotherapy, 2 cycles, and this is after complete regression. Now we have performed a cataract surgery, and 3 years post-op, the patient is doing well with a vision of 20/40. Intracameral chemotherapy is the new kid on the retinoblastoma block, but the case selection is of utmost importance. So this is the last case where again a patient of retinoblastoma. You can see the orbital implant it has migrated into the inferotemporal quadrant. The implant exchange was performed twice, and it was seen that the implant is moving back to the inferotemporal quadrant. So the options in hand were implant removal and with a dermis fat graft, or a customized orbital 3D implant that we performed. A 3D implant was made and it was placed in the inferotemporal quadrant so that the PMMA implant was pushed up, and this is the patient doing well. So we discussed in eyelid the rescue measures as targeted therapy, neoadjuvant chemotherapy, map biopsy, a strict post-operative protocol. In ocular surface, diagnosis noduloulcerative OSSN appropriately and performing enucleation, laser photocoagulation for benign lesions, mostly larger lesions for a scarless outcome, plaque brachytherapy, bleomycin for VLM, preoperative embolization for vascular tumors, radiotherapy for intracornal apical tumors, and a combined orbital and endoscopic approach whenever there is a sinus extension. For intraocular tumors, intraarterial chemotherapy, intravitreal, intracameral chemotherapy, using appropriately customized to each patient, 3D printing of orbital implant. Thank you everyone for patient listening.
Thank you very much, Anasua. We'll open up the floor for questions, if any. Yeah, Raghu.
I have a question for Stephanie. So, do you routinely, like, after you do the blepharoplasty, do you routinely preserve the fat and the skin for a week or so, just to be sure that you don't have a retraction?
Yeah, I don't usually do that because I'm very conservative with my skin measurements. Yeah, so I don't. I mean, all the cases that I showed were really complications referred from outside for the later cases. So yeah, I think it all comes down to measuring twice and cutting once. Yeah.
I think there was a beautiful collection of presentations by every one of them. Hats off to all the speakers. Hats off Tarjani for putting it all together. So I'll just ask a couple of questions for each of the presentations, if that's okay with you.
Yeah.
So when you're talking about certain tissues, and you talked beautifully about the spectrum of ptosis, compliments on just the quality of the videos alone. Which one of those procedures are you comfortable revising the same way? For example, you talked about MMCR for an ophthalmic ptosis, for example, versus when you had to revise, would you resort to a different technique? From posterior to anterior revision to anterior to posterior revision. So I thought that will be something well. And the question I had for Stephanie was, you're right, highlighting about the periorbital bruising and all this stuff, intraoperative hemostasis. Your philosophy on pressure patching, and I would like to get Hosok's opinion as well. When you do eyelid surgeries, even orbital surgeries, what is the role of pressure patching in minimizing the postoperative swelling and hemorrhage?
I'll go first. So a levator, I always prefer to revise by performing levator again. Posterior approach is where there's a little bit of, selection between what's the residual defect like. If it's a minimal defect, I wouldn't hesitate and go ahead and perform more resection of the Mueller's muscle and conjunctiva. But if it's a significant residual ptosis, then I would change to an anterior approach and perform a levator resection. Frontalis muscle flap, I have cases where I do see undercorrection, and as of now I'm still waiting for literature to come up from other colleagues and peers as to how you revise a frontalis muscle flap, because like I mentioned, it's not a surgery that I really like to do. It's just purely out of peer pressure and patient pressure that I opt for that surgery.
Do you think it's along the lines of bell bottoms and skinny jeans?
Absolutely.
The current fashion?
Yeah, I don't patch.
Raghu wants to defend that argument, but we'll give it a date.
I don't routinely patch, do pressure patching post eyelid surgery or lacrimal surgery, but because I did fellowship with Dr. Ganga, orbital surgery, usually I'll patch. Although I think Richard Allen did show his study yesterday. Apparently, our rate of patching is much higher in Asia compared to America, and I think studies have shown actually that there's no benefit to pressure patching, but again, everyone has their own philosophy and from their own experience.
No, the rationale over there is a lot of them operate in ambulatory surgical practices. So they don't admit their patients, keep them in their private ambulatory surgical practices. The liability of visual loss not being picked up by the healthcare staff. Whereas you're working in a controlled environment, we all do the early immediate within 90 minutes and then sometimes later the day. There has been some studies, I think there's a group of study from China which did talk a little bit about it. So maybe Hosok, do you pressure patch your lid and orbital cases?
Actually, when I had a training from Dr. Yunda Kim and Kyung-In Woo, so I was taught I'm not supposed to do patch after eyelid surgery as well as orbital surgery, but actually I do these days. Yeah, so in case of orbital surgery, so when I make sure, so I did a good job with the bleeding control at the end of my surgery. So I do pressure patch for a couple of hours, about 3 hours, and I believe that is that is helpful for immediate bleeding control after the surgery. And similar to that, so every eyelid surgery I perform is a day surgery. They are not, they don't sleep at hospital. So they are supposed to be observed for a couple of hours after the surgery. So during that time, I patch. But usually we have 2 eyelids, so only 1 eyelid is patched. Yeah.
I routinely patch all my patients after eyelid surgery. I apply a loose pressure patch, and on top of it, I put a cold compression. So there's a pressure patch, and then there's a cold compressing mask. So that way, I also train them so they can go back home and continue the same, like put the gauze and then put the cold compression mask over it. So it's patch plus cold compression after surgery. Oh, okay. So I just put a few pieces of little bit of light pressure, and on top of it is a cold compression mask.
Have you tried hyperbaric oxygen therapy? Hyperbaric oxygen therapy for post-op.
Yeah, I think hyperbaric oxygen now is in trend, especially in Beverly Hills and all that for post-op healing.
So we do.
Yeah.
So any extensive surgery, when we are expecting that they're going to have a lot of bleeding, we to give them hyperbaric oxygen. It really reduces the edema as well as the and what would take 3 weeks to resolve would actually take a week.
Mm.
So they really do well with hyperbaric oxygen. The
Yeah.
bleeding also is really.
Yeah, I agree.
Raghu,
it's a trend.
that's how
Not only the
feasible is it to
extensive,
have
but they're
hyperbaric
expecting that it's
oxygen
going to be-
set up in an eye setup? How feasible is it to have hyperbaric
No, I
oxygen?
think you can have it. These physical rehabilitation places, they have hyperbaric oxygen as a part of their own rehabilitation. So if you can have a understanding that
Liaison.
after surgery you shift them there to the nearby center and shift it. So I have one place where I can shift it to they're not they're the physical rehabilitation, they're neuro rehabilitation center where they have a hyperbaric oxygen. But many of the plastic surgeons actually have one unit in their own place. So they have they immediately after surgery they transport it directly down to the basement for the hyperbaric oxygen, and only then they come out to the post-operative ward.
Alice?
Regarding patching, I think the only thing I would do is after an eye bag surgery, especially transconjunctival. So sometimes when you transpose the fat or when you remove, there may be some hidden vessels that may be oozing. So compressing the lower eyelid is really, really helpful to prevent any hematoma and bruising. So that's the
Yeah.
only time that I would come
Sorry to
on.
bring a controversial topic because that's what we are all taught, don't do it, and I do it, and I'm glad to hear other experts in the crowd does it. But for the beginners, be careful when you're patching these cases. Be the one who actually takes off the patch, does that early post-operative review, make sure everything is in order before you put that patch again overnight or whatever it is. Another important point about eyelid surgery, if you're doing only skin reduction blepharoplasties and suture blepharoplasties, it's fine. The moment you open up the septum and manipulate fat, it's not eyelid surgery, it's orbital surgery. Okay, so those are the cases you have to be really careful of. And once a year, you will have a patient with a massive hematoma, and that can result in compartment syndrome. So don't trivialize fat removing blepharoplasties, especially the lower eyelids, especially in our Asian patients who are now taking a lot of these health supplements, and they don't tell you all those things. We only ask about Plavix and warfarin. Be very careful of those things.
Can I ask a question to Dr. Tasani?
Please go ahead. We'll
yeah.
take this as the
So
last
I
question.
really enjoyed the beautiful cases of your PSI. So I also use a PSI, but I'm a very small surgeon, so only pure orbital reconstruction I use PSI. While I saw your beautiful cases, one question in my mind was, have you ever used a PSI in reconstruction of accentuated orbit? Or do you have any opinion about the potential use of PSI for accentuation, orbital reconstruction in accentuated orbit? More particularly, in case of mucormycosis, So we can do accentuate without damaging the full thickness eye. So I usually make an incision on the fornix, upper and lower fornix, to preserve the whole eyelid. In that case, could you think about the potential use of PSI to fool the orbital cavity using PSI, or other issue you can think?
Generally, in an exenteration, eyelid sparing exenteration is what you're mentioning there. You possibly are not handling the bone, it's just the soft tissue that you're removing. So I wouldn't see an indication for any bony reconstruction there. But if you're doing an extended exenteration, where along with the orbit you're also taking out parts of the maxilla or the surrounding bone, then yes, in that situation you could always consider a reconstruction. But to fill the hollow of the exenteration defect, I do not do anything. In fact, the ocularists like to have that hollow. If they don't have that hollow, crafting a very realistic silicone prosthesis or an osteo-integrated prosthesis is very difficult for them. So I like to have the patients have that hollow post-operatively. If the patients are not keen on it, then I do a temporalis muscle transfer into the exenterated socket rather than using a patient-specific implant.
So, that exposure that you showed, right, that one patient. So I feel that most of these patients which have a maxillectomy and they've had this scarring for a while, post mucormycosis as well, the skin is very contracted and it's not very vascular because it's, and post radiation again the vascularity comes down. So when we put in an implant, it actually expands the skin, and because it expands the skin, it just thins out, and that's the reason for the exposure. And also because of the poor vascularity, it doesn't regenerate, and there's no fat cover on top of the implant. So that actually is the
yeah, I think the next session speakers are coming in. Thank you very much for being such an interactive audience. We'll take a group picture quickly and then hand over to the next session and continue the questions outside. Thank you once again to all the speakers and the delegates who joined us.